Hello everyone. On behalf of the PHRN, I'd like to welcome you all to the final Linkage Luminaries webinar for 2021. My name's Felicity Flack and I'm the Manager of Policy and Client Services at the PHRN. I'd like to begin by acknowledging the traditional custodians of all the lands we're meeting on today and paying my respects to elders past and present. First up, some housekeeping. If you have any questions for today's speaker, please type them in the Q&A box at any time during the presentation. We'll answer as many questions as we can at the end of the presentation. This webinar is being recorded and we'll email you as soon as it's available on the PHRN YouTube channel. So now to today's speaker. I'm delighted to introduce Matthew Jose, Professor of Medicine at the University of Tasmania, Adjunct Professor at the Menzies Institute for Medical Research, and a renal physician at the Royal Hobart Hospital. He's passionate about improving the lives of people with kidney disease and is going to talk to us today about how he's been using linked data in his research. Welcome, Matthew. I'll hand over to you.
Thanks very much, Felicity. There's my slides. Brilliant. So welcome. So I'd like to talk today about a statewide approach to identify chronic kidney disease in Tasmania. And today I'm speaking from Lutruwita, Tasmanian Aboriginal land, seas and waterways. And I acknowledge with deep respect the traditional owners of this land, the Muwinina and Palana people. Acknowledge their elders past, present and emerging. So what I'd like to talk today about is our study, which is called CKD TasLink. Really, what have we done? What's unique about this linkage and what outcomes impact have occurred so far? And then where do we go to next? So for those online who don't know me, I'm a kidney doctor, and just saying before, I use the words, I'm Matthew, the kidney doctor, quite a lot. I'm a staff specialist here at the Royal Hobart Hospital. I'm also a Professor of Medicine for the university. I play a number of roles on national groups, which is our Australian-New Zealand Dialysis and Transplant Registry, which captures everybody who's on dialysis or transplant in Australia. I'm on the National Indigenous Kidney Transplant Task Force, our Australasian Kidney Guidelines, and a member of the Strategic Action Plan for Kidney Disease federally. I work in Tasmania. For those who don't know Tasmania, it's got a population of just over 500,000 and everywhere is rural, regional or remote. There are no metropolitan areas, as my colleagues keep telling me around Australia when they do a metropolitan study. And last year when I had to present, I presented from the tip of Flinders Island, which is up there where the dot is. Now, Tasmania has an older population, a lower median income, and the last Australian Health Survey, a lot of smokers, a lot of people with disease and hypertension, and many people who do no exercise. If we talk about chronic kidney disease or CKD, it literally means your kidneys are damaged, they can't filter your blood properly. The majority of that is due to diabetes, high blood pressure, inflammation in the kidney called nephritis, or a genetic kidney disease called polycystic kidney disease. And usually it affects both kidneys so that the function does decrease sequentially. Now, the way we measure that function is to report what's called an eGFR, an estimated glomerular filtration rate. To do this, we do a blood test for creatinine. Creatinine comes from muscle, it runs around the body and gets excreted through the kidneys. So at steady state, it's a steady concentration, and any change in that does equal change in kidney function. So if we take your age and gender and this creatinine, put it into a formula, and it actually gives you eGFR, and the normal is greater than 90 ml per minute. And so most of the time when we're talking to patients, we talk about percentage of kidneys. So if you're up at more than 90%, that's normal. So it's eGFR is what we report by measuring the creatinine. And if you look at what happens over the course of kidney disease, the creatinine, the eGFR does decline over months and years. And we've divided it up for no other reason just than to classify it in stages 1 through to 5. So by the time your kidney function is down less than 15 ml per minute, you're actually in kidney failure, or what we call stage 5 CKD. And the pathway does lead to kidney machines for treatment for kidney failure. So many people actually know people who've got a transplant or dialysis. We've now got over 32,000 people in Australia on dialysis or transplant. So this slide's a little bit old, but it's from the State of the Nation report back 5 years ago when we only had 21,000. So there's actually been a 50% growth rate in the number of people on dialysis or transplant. So if you think of the 5 million people at risk around Australia, the 1 million people with early kidney disease, the 500,000 people with severe kidney disease, you can see why there's actually a need to look at this population at a population level around the country. Because actually it's the number of people coming onto our program is just going up and up. So this data is from Anne's data. So this is the number of new people coming on to dialysis or transplant in Australia on the left-hand side and New Zealand on the right-hand side. And they're basically identical, just different numbers. And every person we put on dialysis is costing the taxpayer $50,000 a year. So it's not cheap. And the burden of cost to this country is becoming enormous. And in America, it's over a $4 billion a year industry. So quite expensive and quite technologically burdensome. But there's variability right around the country. Again, from the State of the Nation report back 5 years ago, you can see it does vary. It varies by Indigenous, First Nations people have got the highest rate in the country. But if you focus on non-Indigenous people, Tasmania has the highest prevalence in Australia of kidney disease in non-Indigenous people. Yet in the community, we actually only dialyse 398 per million. So actually we're 50% lower in our rate of dialysis than the rest of the country. So there's a mismatch between kidney disease in the community and our low rate of dialysis. And so that's where we started off. The original idea of this is to try and understand how high kidney disease in the community translates into low use of dialysis in our hospitals. So let's look at what we've done so far. And unfortunately, it comes with a historical perspective. And my naivety back going 12 years ago, back in 2008, is we did our first attempt at this is simply a blind data dump. We didn't link it. We just took all the pathology data in Tasmania, blinded, and they got them to give it to us. We managed to publish this on chronic kidney disease in Tasmania back in 2009, including 370,000 people. And it allowed us to standardize that creatinine measurement. So we got all the labs in Tasmania reporting the same measurement using the same assay, which is an enzymatic assay, internationally aligned, and able to retrospectively standardize it using average of normal statistical technique. So the good thing that came out of that original study was actually getting the pathology data standardized across the state, but it was unlinked. The pathology recording was, by name. So I might have been in the pathology database as Matthew, then Matthew David, then Matt. So there are many duplicates in there. And we got yearly updates for a number of years, but we actually stopped it when the number of people in our data set was actually greater than the number of people in Tasmania. So our first attempt at a blind data dump made us realize, look, it wasn't bad. It gave us an estimate, but actually not really a good methodology for really honing down on kidney disease. So our second attempt started back in 2016, when we saw that State of the Nation report where the data still said we're the highest non-Indigenous in the country. So in October 2016, now 5 years ago, we put together a linkage protocol. We went through ethics and got funding and began the actual linkage in 2018 to data at the end, using inclusive data up to the end of 2017. And we got all the data from the custodians in about the middle of 2019. So it took us 3 years to actually go from protocol to receiving our data. And we were just starting to look at it when COVID came along. So we're fortunate in 2020, whilst COVID was upsetting the world, to get the methods paper published, to set up collaborations both within the state and nationally, and then to fast forward to where we are now. So this is the protocol that we published last year. We're just really looking at trying to agree on all our definitions of what is kidney disease, how we're going to measure it, and put that out there for the community. So what I keep getting told about this linkage is the uniqueness is sometimes bringing all this together, the multiple data sets, and the pathology element to it. So this is our first linkage that we did back in that 2018, 2019. So we took everybody in Tasmania who'd had this measurement of creatinine, a blood test for creatinine, over this 13-year period from 2004 to 2017. And we had about 4 million results from 3 pathology providers and about 1 million results from my hospital provider here. And with that, the linkage there was able to identify just over 500,000 individuals, of which we identified 383,000 people over the age of 18 who had a Tasmanian postcode. And if we looked at the last 5 years of this data set, you can see that 86.7% of the census population of Tasmania had actually had a serum creatinine. So this technique captured 86.7% of adults in our state. We linked it to the public hospital admitted data set, the emergency department's data set, the cancer registry and the death registry. We also, because it's a kidney data set, linked it to the Australian New Zealand Dialysis and Transplant Registry. So we're able to take the kidney results in the community and link it to who does get treated with dialysis or transplant and who dies and who comes to hospital. So we're able to do that as the framework, as the first linkage. We've just, this month updated it to data from up to December 31st last year. So we've now got 17 years worth of data and just nearly 6.5 million pathology results. What have we done in this new data set? Well, we've taken it up to 87.8% of the Tasmanian population now. So incrementing, we haven't got 100% because young people don't always have this blood test, but we're really pushing it up to really doing whole of population capture. As well as greater numbers in there, we've brought in the perinatal data set. Because for people who've had babies, you realize that people get hypertension, they develop protein in their urine, and kidney disease has a profound impact on pregnancy, and really want to look at the gender differences, which I'll talk to you about in a minute, and wondering what role does pregnancy have on the follow-up of developing kidney disease. So we look at the actual linkage. This is the largest linkage that our data linkage group had ever done. So we talked about Hobart pathology, which is actually Hobart, Launceston and Northwest pathology. So 3 different groups. They're all in the Sonic group themselves. And then Pathology South, which is the Royal Hobart Hospital Pathology. And you can see the number of records for the number of individuals in the linkage 1 and the linkage 2, combining for nearly 6.5 million pathology results in around about 550,000 individuals. Some of the issues that came through in dealing with private pathology providers is the time and effort it took to actually do the data extraction, the way that the data was actually recorded. So if I go in there and have a pathology test, it may be recorded in a number of ways. Sometimes the address is missing, sometimes the postcode, a whole lot of different things. And then the actual software to be able to extract that many records in a way that we can do the data linkage, as in a de-identified way, and then to actually link them back together so we can receive the data, was a significant hurdle and actually required quite a lot of time and effort to do that. We geocoded down to street address and were able to assign mesh blocks within the data linkage unit, but our agreement with the private pathology provider is so we didn't upset their customers, as in the doctors in small towns. We're only going to report by SA2 or populations for around about 5,000, rather than down to the mesh blocks. They didn't want us picking on individual doctors saying their lipid results are really high or their kidney outcomes are terrible. So we're actually reporting it at a slightly higher level at SA2 region. This is taken from the data linkage report, and you can see the methodology there, the sequence of linkage that went through, taking the pathology, the other data sets that are already in the master linkage map, and then bringing in the larger Hobart pathology file in there, going through exact matching scores, and then probabilistic processes there to try and hone down. But even having done that, our data analysts are still identifying people who actually haven't quite been linked up perfectly, as in they've had pathology after they've appeared in the death data set. So even going through this on such a large data set, there still requires a further level of cleaning from our data analysts to do it. Now, the other bit is dealing with a whole lot of pathology. Now, fortunately, we'd standardized the creatinine assay, but I'll show you in the next slide, we didn't just take creatinine, we took a whole lot of other pathology variables, which have got different assays in different labs. And over time, there've been federal policy changes where the use of that pathology does change. And then even today, even as late as an hour ago, we were having missing babies in the perinatal data set because taking a creatinine, some newborns appeared both in our data set as participants, as well as, but they were then missing from the baby link. So actually capturing both mothers and babies when our actual cohort was based on creatinine just took an extra layer of challenge there. So a whole lot of challenges in that linkage, which is we've all learned from, and I think it's really important going on when you're bringing in pathology data into this. So these are the pathology fields which we actually took. And as a kidney doctor, one of the things I do know is kidneys affects everything. So we're able to take a broad range of pathology fields because they're important in kidney disease. So we looked at the creatinine, which I've talked about, which also is important with sodium, potassium, bicarbonate, chloride, all those electrolytes. We looked at uric acid because that's to do with gout, which is increased in kidney disease. Iron and anemia is really important in kidney disease because many of our patients are anemic. Diabetes causes 40% of kidney failure. So we had to take fasting glucose and HbA1c results. Vitamin D is important because the kidney actually activates vitamin D. Lipids are really important because most of our patients die of either cancer or cardiovascular disease. So we needed to look at both cardiovascular disease and cancer. And of course, for kidneys, the money's in the urine. So we really needed to look at urinary protein. So this is why we're able to justify a very large range of pathology fields. But as I said, the standardized one is creatinine, not all these other ones. And if you look at creatinine, what we did identify, it was the most common test that the population had. So if you look at here, you can see that women have slightly more likely to have a creatinine test than men, but we're able to capture 50% of the population in any 1 year, which is why when we looked over a 5-year period, you could see that 86.7 or now up to 87% of the Tasmanian population is having this test. You may not have it every year, but actually over time, together that we're able to look at the kidney health. And if you look at the social determinants of health, kidney disease is one of those things where the social determinants are so important. So you can see that people who are living in the most disadvantaged areas are the ones who are most likely to be having these pathology tests. Now, these are pathology tests ordered by their doctor. So we're presuming the doctor thinks there's a problem and orders the test. This is not a health survey. This is not a random sample. This is actually ordered by doctors. So real life, but on a population basis where we're capturing 97% of the population. And then you can see other trends such as capturing vitamin D. And you wouldn't have thought vitamin D existed before 2010, but it took over from the vitamin C trend. So the last decade, we've been measuring vitamin D and trying to pretend we know what to do with it. And you can see that women are more likely to have a vitamin D test than men. And we've gone through that excitement period and trying to find a realistic expectation of how many vitamin D tests should somebody have in any 1 year. And you can see the results of policy changes. So this is the distribution of results for HbA1c, which is a measure of glucose control for people with diabetes. So up to 2015, only people with diabetes could have this test, and it was able to look at the control of that. Once late 2015 hit, the federal government changed the Medicare reimbursement so you could now use it for screening tests. So they could give one to me. I'm not diabetic, but my GP could do a screening test for diabetes, and therefore you can see the skew or the distribution of the results are skewed to the left, where more people without diabetes were being tested, as in the population had a lower HbA1c, and that's the distribution of results. So really interesting to look at that. One of the other ones, which I won't show you, is the Catalyst episode on statins use. And we looked at statin use to see whether that affected lipid testing in Tasmania, and it didn't. So I haven't shown you the results here. But let's come back to kidney disease and look at who has chronic kidney disease in Tasmania. So the bottom line is 6.5% of our adult population does have kidney disease in our data set. And that's based on the international definitions of 2 readings 90 days apart, or if you do just 1 reading any 1 year, 12% of the population meet that. It's greater than our national survey using Medicine Insight data, which is GP data of 4.1%, which we published a couple of years earlier, and higher again than the AusDiab or Australian Health Survey back a decade ago. So you can see over that decade, and using our state-based data, that the rate of kidney disease is increasing around the country. And we can see that when we break it down by stage, this is the different stages of chronic kidney disease in Tasmania. And when we look at the overall numbers, you can see even in our state, there's been a 70% increase in the number of people identified with chronic kidney disease, even in the state of Tasmania. If you extrapolate that nationwide, that's a little bit terrifying when you think of the cost of treating people with a kidney machine. So this year we've published our Island Medicine paper, really reporting on the population trend. So Island Medicine using data linkage to establish the kidney health of the population of Tasmania. So it's taken us 5 years to get to this point, to really look at the prevalence of Tasmania and look at the trends over this 13-year period. What we've shown now is there are gender differences. We know in the community, women are more likely to have chronic kidney disease. So the majority of people in the Tasmanian community with chronic kidney disease are women. If you come to my dialysis unit, the majority of people on dialysis are men. And interestingly, more men receive transplants. So why are there gender biases here? Is it a disease, a person problem, or is this practice patterns? And actually with our own intrinsic biases over that pathway? Or is it like one of my sociologists who was doing some research with me, her theory was that men liked our technology, so therefore men were more likely to use the technology rather than actually not. Whole lot of reasons. In Darwin, one of the theories we had up there is the women didn't turn up to dialysis because they were looking after the family. So there are clear gender biases here which deserve more work to look at and try to explain that. There are also geographic differences in Tasmania. Now, using the Shiny apps, we're able to produce these maps for local government areas. On the right there, you can see we can produce both areas which have got the greatest number of people with chronic kidney disease, as well as the age standardized prevalence, where some communities up to 15% prevalence of chronic kidney disease. And we can actually give this to communities around the state, looking at where people are with the highest rate, and we can start to do planning for our health services and where their needs are. So this is a map of Hobart, just looking at the eastern shore with the high rates and different areas. And again, it goes by the affluent suburbs. The more affluent suburbs have lower rates of kidney disease. The same in Launceston there, and then up the northwest coast where you've got Burnie and Ulverston, again, high rates of kidney disease in those areas. And if we look at the prevalence or incident rate ratios and compare it to the south, which is where I'm based, you can see that as you go more rural and remote up into the northwest, that the greatest growth rate is in those areas. So the north of the state, up around Launceston, is the prevalence is about 6% higher, but the incidence is 13% higher. In the northwest, which is rural or remote, the incidence is 47% higher rate ratio and the prevalence 18% higher. So again, there's very much a geographic and rural and regional and remote differences within our state. We also then want to look at what happens to people with chronic kidney disease. So this is a river plot. And now, because we've now got 17 years of longitudinal data, we can start to map out for people what will happen to them. So this is people who've got stage 3 or stage 4 kidney disease and follow them over 10 years. And you can see that people with kidney disease either end up on kidney machines or they die. A few of them get better, but many people with low kidney function, when you look at them over the longer period, they they don't do very well. So I've got a paper in press with the Medical Journal of Australia at the moment, really looking at this. So on the left-hand side, if you take the young people, the people under the age of 65, and follow them from the time their kidney function hits 30% or less, and follow them for over the next 5 years, 41% will be alive with kidneys who are still working. 41% will have developed kidney failure, which is started treated with our kidney machines, or have a kidney function less than 10%, and 18% will die. But if you look at in these older age groups, over 65, over 75, and over 85, you can see that the greatest growth rate is in people who are dying. So if you're over the age of 75, more than half will die, and only 5% will still be alive to actually get onto our kidney machines. And then once you're over 85, death is the likely outcome for people with low kidney function. And we're able to take our data, which is on here on the left, and show this 41% of kidney failure here is very similar to that published from the Canadian group in JAMA in 2020, where 48% of their population less than 65 developed kidney failure. But what is interesting is of this 48%, 45% of Canadians there were treated with kidney machines. Whereas here, you can see that only 20% of our patients were actually treated with kidney machines. The other half of that 41% weren't treated with kidney machines. So there is practice pattern differences even in this younger age group. And as you go into the older age groups, you can see that the overall rate of kidney failure is about the same at 22% or 13%, but you're more likely to be treated with a kidney machine in Canada than you are in Tasmania. We're starting to wonder why the poor outcomes for Tasmanians with kidney disease. Are we withholding an important treatment that we should actually be providing for everybody? Because we've linked hospital admission data, we had ICD-10 codes for everybody, and we're able to look on about half the population we had in the data set, 49%, had an admission. Or if you had kidney disease, 73%, so 3/4 of our people with kidney disease had at least one admission, and therefore we had other comorbidities. And you can see that this is a graph looking at people on the left-hand side, those without kidney disease, versus those on the right-hand side who do have kidney disease. And so you can see the increase in congestive heart failure, cancer, diabetes, even things like dementia or liver disease is increased in people with chronic kidney disease. And importantly for the funders, our patients stay longer if they've got kidney disease than those who don't. And if we start teasing out some of those important things, this is simply looking at cardiovascular disease in our people with kidney disease. You can see that virtually everything is, the relative rate of it is increased. So if you look at that, anywhere between 5 and 11-fold, and our kidney patients are much more likely to get a pacemaker inserted than people without kidney disease, and more likely to die, and especially a cardiovascular cause of death. So just because it's kidney disease doesn't mean it's not affected by everything else. It actually affects every part of your body. So we started looking at some of these treatment pathways for people with kidney failure here in Tasmania because we had this linked data set. So the aim of this project here was to report for people with kidney failure the outcomes on those who did get treated with dialysis versus those who didn't. Because our data was different to the Canadians, we wanted to check that we weren't withholding an important treatment for people. So when we looked at these outcomes, we started to report things that were important to patients. And we based this on what's called the SONG outcomes, Standardizing Outcomes in Nephrology. It's an international group, and they looked at co-design, looking at what outcomes are important to patients and clinicians and health providers. So this is one of the key outcomes, which is if you start on dialysis with a kidney function less than 15, you'll live a median of 5 years, 4.9 years or 1,800 days. You can see the interquartile range there. So that's treated with dialysis, how long you'll live for. If we don't treat you with dialysis, once your kidney function is down low, your median survival will be about 2 years or 705 days. But there's a fair range in there. So clearly there is a difference in how long you will live or how long people have lived with or without dialysis. We're able to identify that people with dialysis will have 2 to 3 times the number of presentations to the emergency department and about 3 times the number of admissions to hospital there. So we start to develop this package or pathway for people so we can start informing the next person who comes along that this is what the pathways look like for them. One of the other things people want to know is how many days do they get off for free time? So once you quantify that, you realize people come to me 3 days a week on a kidney machine for the rest of their life. So 3 days a week you're with me, and so we're able to quantify how many dialysis days, how many days do you get away from us? And we quantitated that on average, sort of the median ones of just over 1,000 days. So you still get more days off than if you didn't have treatment overall. But once you start breaking that down by age group, so this is the young group, you can see that yes, there's a survival benefit. Yes, you get more dialysis-free days, but you get 3 to 4 times as many emergency department presentations and hospital visits. If you start kicking up that age group, there's less of a benefit. So once you're over 65, you don't get many more days away from us as such. Without dialysis, you'd survive for a median of 828 days, and you get 869 dialysis-free days, but you still get double the amount of emergency department and double the amount of admissions. Older again, it's neck and neck, whether you get more free time without our machine. And then once you're over the age of 85, dialysis probably does you a disservice. But the important conversation is you'll still live about 6 months longer overall, median-wise. But look how much those interquartile ranges overlap. So you'll still live potentially for another 6 months longer as a median score, but you get less free time. You only get 432 dialysis-free days if you're on my machines. If it's time you want, you're better off not having our treatment, because you'll still end up in the emergency department at least twice as often as if you weren't treated, and you'll still have more admissions to hospital. So we're able to start putting together this package for people with individual age groups, and we're able to do this by gender, we're able to do this by location, rural location, and start to tailor it as an information package for treatment pathways for people, so they understand in their local community of Tasmania what things look like depending on their personalised story. So rather than looking at international data, we're able to bring it back to really local data and what things look like in our hands. So to summarise all that treatment pathways, using kidney replacement therapy, particularly dialysis, people were alive for longer than if they didn't get treated, but you've got to have more medicalisation, visits to the ED and visits to the hospital. If you don't have dialysis, you're likely to be in the last 1,000 days of your life. And that's where it's really important to look at where do you want to spend that time. So what outcomes and impact have we had so far with this? We had quite a strong consumer reporting component of our work. We've developed these consumer flyers, and there were 5 of them overall. This is just 3 of them, really trying to explain to the Tasmanians what it is we did, what did we find, and what is really important there. And these are all up on our public website for people to be able to look at. We've informed the current strategic plan within the state, which is currently in draft form and will be put out, because as you can see, is a gender and geographic biases within the state that we need to understand and provide health services to. And we've provided information to the National Strategic Action Plan on Kidney Disease, which was launched last year by the federal government. So use of this data, longitudinal data, which is unique in this country to do with kidney disease, is really important for not only informing patients, but also government policy and health service provision. We're starting to look at our technique against other methods of looking at kidney disease in the community. So we're fortunate to get a federal grant, and we've called the CKD3 collaboration, which is really to identify the progress in identification and management of kidney disease in primary care across 3 jurisdictions, which is Northern Territory, Tasmania and Victoria. Now, this is 3 different methods of looking at that. We use data linkage. The Northern Territory have actually developed their own computer system which brings in GP data and hospital data together. And Western Health in Melbourne are using the PenCat tool in GP databases to actually bring in their data. So 3 different methods of looking at things to look at what's the best way of identifying kidney disease in the community, especially in some of our high-risk Aboriginal and non-Aboriginal communities across the country. So this work's still ongoing, and that'll be really exciting to see which method should we do, because our data linkage is great, but you can see it's sometimes it's a little bit hair pulling because it's a little bit frustrating. The Northern Territory one is actually weekly updates. And so somewhere between those may be the right answer about how do we get accurate, useful data on a timely basis across the country. So what comes next? Well, we've only just got this data. So this is data up to 31st of December last year. So this is the number of tests for looking for diabetes in Tasmania. And again, you can see it really goes down advantage or disadvantaged lines. So a massive increase on looking for diabetes in Tasmania, and it's working. So this is the age standardized rate of people with biochemical definitions of diabetes is in this state is just going up and up and up. And you can see the big jump it went from 2018-19 up to our COVID time last year, where people's diabetic control, or at least HbA1c, is getting worse. So that's a bit of a scary line for people who look after diabetes, people with diabetes, and knowing that diabetes causes kidney failure, that's scary for us in the kidney world. We're able to map this out. So for everybody in 2020 who'd had an HbA1c, nearly 30% of them actually met the definition of diabetes. So again, scary numbers for what is a really severe health condition and the flow-on effects. And we're able to look this again right around the state there, and the map of diabetes overlays the map of kidney disease beautifully. You know, you could almost superimpose those 2 conditions together. So again, chronic disease goes together. We're also able to look at high cholesterol, and we've got some of our members interested in familial hyperlipidemia. So this is a map of LDL greater than 6.5, so very high cholesterol readings around the state. And again, we can overlap this with our hospital admission data for heart attacks and cardiovascular interventions, because that's where both kidney disease, diabetes, and cardiovascular disease all intersect there. And you can see that on the right-hand side there, the SA2 regions, which have got a number of incidents there. With the perinatal data set, we're joining in this, which is really giving information for parents or expected parents around what happens if you've got kidney disease, what's the likely outcome for you and your baby if you're on dialysis, or if you've got mildly impaired kidney disease. We don't have that data internationally. So again, this is a national study that we're joining in on and looking at that at the moment. Again, trying to give better information for people with kidney disease and the outcomes. We have a whole lot of other concurrent work going on, including health economic work. I've got a mathematician who's doing some network analysis, which is fantastic. And some of our strong thing is really looking at the last 1,000 days with chronic disease, as in how do you help provide best care for people without a dialysis machine, knowing that I've just shown you that many of our people do die. How do we do it without just adding in technology and things? So using this data to provide treatment closer to home. So with that, I'd like to thank everybody involved. We've had a number of funders, which is the Tasmanian Community Fund, the Royal Hobart Hospital Research Foundation, and the Australian Government through the CKD3 collaboration. Primary Health Tasmania have worked very closely with us, and they've provided funding for this as well. And the in-kind support has been fantastic from the pathology providers of Hobart Pathology, Pathology South, and ANZ Data, And a whole lot of people that we've had to try and keep them focused on kidney disease, because that's where our ethics and governance is. But knowing this is a fantastic data set, that actually we're looking at ethics and governance approval for better use of it, because there are a whole lot of other things that can come from it. But if I keep reminding people, it started with a serum creatinine. So it's focused on kidney disease and all the things that flow from it. It's not a one size fits all. So really important to realize what its limitations are. So with that, Felicity, I'd like to say thank you, and I'll stop my presentation there, and I'm going to stop sharing.
Thank you, Matthew. That was a fantastic presentation, and the breadth of work that you've been able to do by linking all this data together is amazing, and a fabulous demonstration of what can be achieved, and I'm sure there's lots more to come. So we certainly have some time for questions. We've got some questions up already, but if anybody else has more questions for Matthew, feel free to type them in the Q&A box. But let's start perhaps with the ones that we've got. So the first one really is about funding, and Simone is interested in hearing about your TCF funding particularly, and what you used it for.
Yeah, thank you. So the Tasmania Community Fund, what they funded is actually the, we've got $90,000 to kickstart this. It actually, I think about a third of it, about 30 to 40% went to the data linkage unit to actually pay them to do the large data linkage. About 10% of it went to the Hobart Pathology, like the private pathology provider, to pay person time to extract the data. And the remainder, few dollars and cents, went to Tim Saunder and Alex Kitsos, who I didn't acknowledge. They're the data analysts who've done all the work on this, and I'm quite sure have never paid them enough and underappreciated. But it's really to get it up and going. The majority of funding did go to the data linkage group and the data analysis group to get going there. And it's my job to try and bring in extra funds to really get the benefits of this data set out with some really high quality analysis. So that's where we're at the moment. Unfortunately, as a clinician, that impacts on my grant writing time. So yeah, stay tuned.
Okay. I think next one might ask you about the pathology data in particular, because as Meryn Smith, who's our CEO, actually has popped in the questions, pathology data has certainly been a game changer for this project, but the linkage of pathology data to other linked data in other jurisdictions has now been prioritised by the PHRN, and we're actually funding a project to try and increase the amount of pathology data that's routinely linked in across as many jurisdictions as we can. And this experience, I think, is really relevant to that project. But Simone was also asking about how easy or difficult was it to obtain the pathology data in Tasmania, and perhaps you could talk us through what you needed to go through to get access to the
thank you. I'd like to say it was easy, but it was easy from, you saw how long it took there. And so part of it was the Tasmania is a small community. So it's when I arrived down here from working elsewhere, I found the best way is simply go and knock on doors. So very much a person-to-person relationship works very well. So I know all the pathologists who work in all these labs really closely. And we'd done that first data dump back in 2009. So we actually had a 10-year working relationship. We'd already standardized the test for creatinine. So we'd actually had all that before we came into it. So that was relatively easy. I know Nardine in our data linkage unit says no, it wasn't, in terms of when it came into their group. So certainly within data linkage, yeah, the private pathology weren't set up to match up all theirs, and you realise their systems just weren't set up for data linkage. Now, when I go around the country, what also isn't set up, it drives me batty when my transplant patients travel the country and I get results back from other states, and I can see instantly they use a different assay for measuring creatinine. Now, the Jaffe reaction was developed in 1890, and there are labs in Queensland that use the Jaffe reaction. So the creatinine they give me will be 20 to 30% higher when they're in Queensland versus ones down here. So who uses a test back from 130 years ago? They do because it's slightly cheaper than the enzymatic. So until we actually get standardized stuff around the country, and yes, they'll argue that it's IDMS aligned, but they're using different assays, and that's the nature of the private pathology. So that's one test, that's creatinine. You then take it into some of these other important things and you realize, look, we're not all measuring the same thing the same way. And the pathology group, yes, they have their QA process and things, and they're really stringent there, but it's still not standardized, really well. So there's a whole lot of work that needs to be done there so that you can actually know that you're linking the same thing, and actually the numbers aren't just going up and down because they're going to different pathology laboratories. Ours work well because of that person relationship, the person-to-person relationship. And I meet up with them quite a lot, both our local people as well as Hobart Pathology, because it's just down the road. And really nothing gets published from this without them knowing about it, because it's actually, it really is about that, that relationships that I don't want to ruin that thing. So it's a Tasmanian thing, but I think it works very well.
Excellent. Let's keep moving. The next question is around your comments about the geographic levels that you were able to report the data at. And John asks says, if the doctor's outcomes regarding patients are terrible, why not notify them in a nice way?
Yes, it's a great question. So nationally, we're having that discussion. So I'm involved in ANZ data. We look at the outcomes of all our dialysis and transplant units around the country. We've put de-identified data up until about 3 or 4 years ago. We now put identified outcomes on our national data. So it's been an evolution over time about naming up units as such, because we know units who are in lower socioeconomic groups do have patients with more disease versus others. So there's certainly the social determinants there. So there are reasons why people do have poor outcomes, and it may not be the doctor's fault as such. So we know in the northwest of Tasmania, there's a whole lot of social determinants that a doctor cannot fix. For example, one of them is school in Tasmania only goes up to year 10. Once you finish high school at year 10, you actually have to go to a different place called college, to a year 11, 12 college. So that's where up until a few years ago, many people dropped out of school at year 10. So we even have educational levels that are lower than other states. And that's where, from a doctor point of view, look, that's really challenging. We can't get GPs to go there anyway. So that's where we don't want to scare off doctors. And then the other thing is, to me, this is a blind data system. I don't know who that doctor is. And the fact that we know that person lives in Burnie, I actually don't know whether they go to see the doctor in Ulverston and have the pathology test in Ulverston. So we have to be really careful about who we're blaming for that test result. So that's where what we are doing is working with Primary Health Tasmania. I've done a number of talks for GPs and simply putting the maps up there for people to look at their own data and start to get people used to looking at their own data. And I can tell you, most doctors are really proud of their work and don't want to see them as the, outside the 95th percentiles. They want to be shown they're doing good work. So I don't think we have to name and shame. I think there's enough incentive for people to learn from it themselves. But I am a big one for actually open transparency and open data reporting, as long as it's quality reporting.
Sure. Next question is from Alison, who's asking, do the gender differences in prevalence and treatment also play out in mortality differences, rates and age at death?
Yes, they do. So I didn't quite show the whole story on the gender. Gender is really interesting, and I keep on talking about gender, but as a white middle-aged male, I'm trying to encourage others to actually pick up on that, because the same as my work with Indigenous people, I really just try to support Indigenous researchers to actually report the Indigenous data that we do have that we haven't reported on. So from the gender point of view, what we do know is the more kidney disease in women, but more treatment in men. What we do know is male kidney disease, kidney disease in males progresses faster than women, and mortality rates in males are higher than women. So same as national mortality figures, that men die more likely to die than women. So those things do play out. We also know diabetes is higher rates in men, hypertension, cardiovascular disease. So all those other chronic diseases or comorbidities are all there in males. So what we're trying to do is put that whole picture together. But at the moment, our ethics and governance approval is reporting on kidney disease. We're actually going through a process to actually get ethics and governance approval to talk about that whole package of chronic disease. But we've only got the data that we've got, which is pathology and hospital. We haven't got GP data. And the GPs I work with will tell me, we haven't got what their blood pressure is. We haven't got their mental health. There are a whole many things that we don't have in this data set. So in the end, there are gender differences. Is this data set enough in its current form to really answer the differences in a high quality analysis? I'm not sure yet. And I've got a number of young female researchers who are actually leading that part of our study.
Just a question for me, thinking about how you could augment this data set by linking in some additional data collection. So you've mentioned GP data, and that certainly would be interesting in bringing in that primary care data. Are there any other data collections that are on your list of priorities to bring in at some point?
Yeah, yes, it's something which again, I'm influenced by our data linkage unit, which gets a bit scary every time I come to see them. One of the things you've got to be careful about is that I want more data sets when actually we haven't properly analysed the one we've got. So that's I guess the rule I'm setting myself at the moment. Don't just be greedy, actually use the one you've got properly. But it comes under the umbrella that's about a 10-year idea, which is actually the island medicine idea, which is a small state of Tasmania. Why aren't all of our data sets automatically linked? As in, the aim is our data linkage unit actually has every data set in their master linkage map already, whether that be all the research projects, everybody's consented for that, or the hospital people. So we want a connected island, and we should be able to get it because we not only have health data, we actually have environmental data. So we have air pollution, smoke, we have water quality, soil quality, we have education data sets, all the NAPLAN ones. So there are a whole many data sets that we know we can go from social determinants through mental health, through actual health outcomes that we could link. What we would all like is actually that there are, at least in the master linkage map, or at least in a researchable data set that could be used for everybody, rather than just me as a kidney doctor saying it has to be about kidney disease. So again, it's like my first attempt at a blind data dump. You learn so much from every project you do, and you realize, well, it's good for a purpose, but not quite the next purpose that you want.
Well, I think that actually might be a really nice place to finish, because that's a spectacular vision for medical research in Tasmania, and possibly a nice concept for others to think about further afield. So thank you once again. That was a really interesting presentation, and I'm so pleased to see what's been happening in Tasmania. And thank you for everybody else who joined us, and I hope everybody has enjoyed our Linkage Luminaries series this year, and we're currently starting to put together a program for next year, so hopefully we'll see you all back next year sometime. Thank you once again, Matthew.
Thanks, Felicity. Thank you.